Good morning. Hello, and thank you for joining us today for our virtual Healthy Minds, Healthy Bodies seminar. As a reminder, all lines will be muted. The presentation will also be recorded and provided in a follow-up email. Please submit any questions via the Q&A box. Questions will be monitored throughout the duration of the seminar, and time will be reserved at the end for the presenter to address these questions. We will do our best to address all questions that have come up during the presentation, but if we reach the closing time of today's event, for any questions we were unable to address, answers will be provided in the follow-up email that you will receive, which will also contain a link to the webinar recording. A link to a survey will be provided at the end within the Q&A box, so you may give us your feedback regarding today's presentation. Our presenter today is Dr. Kelli Baum. She is a co-medical director of the Total Joint Replacement Program with Samaritan Medical Group Orthopedics in Albany. Welcome, Dr. Baum, and I'll now hand it over to you.
Thank you. Thank you, everyone, for joining us. If for any reason you can't hear me along the way, just go ahead and let me know. And again, if there's any questions, I'll try to, if you are able to type them into the question box, we'll try to address them as we go. But again, we'll have time at the end for anyone that wants to ask anything. So again, my name is Kelli Baum, and I work along with my partner, Dr. James Ryan. And we direct or are in charge of the Total Joint Program based out of Albany, but within Samaritan, we do a good majority of the joint replacements that take place here. We have a pretty comprehensive joint replacement program. We recently just got approved for a fairly large accreditation that we've been working on for the last 2 years that sets us apart as one of a designated center of excellence for joint replacement. So that should be coming out here in the next several months once it all gets finalized, but we're very excited about some of the things that are happening here. So I'll go ahead and get started. The goal here is to talk to you about hip and knee replacement. And I want to go over kind of the basics to give everybody an understanding of what we're talking about. Most of the time, these are procedures done for arthritis, which we'll go over as well. And it's not just about surgical options, but what other options are available. And then we'll go into knee and hip replacement, both describing the procedures and showing you kind of what those replacements are made of and what that looks like. And then some of the special things that we do here, utilizing technology to make the surgeries more accurate and more precise. So we'll go ahead and get started. So starting with knees, knee arthritis in particular. Understanding what a knee looks like is important so that I'll get a little pointer here so we can point to some things. So the knee is comprised of the thigh bone up above called the femur and the shin bone down below called the tibia. And then the kneecap, which sits out in front and moves through the groove on the end of the thigh bone. In addition to the bones, there's ligaments both on the sides of the knees and then inside of the knee that provide stability. And when a knee is working well, all those things should function together to provide pain-free motion, but that's not always the case. The best way to think of the knee joint is sort of like a hinge joint, although it is more complex than that. It moves in many motions. It doesn't just rotate around a hinge. It also slides or let me back up. So it rotates around the hinge. It also turns or pivots and it glides back and forth. So it moves in many degrees of motion, which is why it's very complex and why it is prone to injury. Within the knee, there's two shock absorbers called the meniscus, along with the cartilage, which is the coating on the end of the bone that provides shock absorption and cushion. And then, like I mentioned before, there's those ligaments inside the knee. Those are called the ACL and the PCL, which provide stability. So the hip is much different. The hip is like a ball in a socket. And the top of the thigh bone, called the femur or the femoral head, is the ball. And then inside of the socket, or what's called the acetabulum in our pelvis, is the socket. And those are surrounded by all the muscles within our hip and the leg, and then the ligaments that attach them. So the thing that is similar between a hip and a knee is that, number one, they both have cartilage. And number two, they're both joints that we walk on, which is different than our shoulders because most of us don't walk on our hands. And so they're prone to arthritis in a much different way because we use them every day of our lives. So what is arthritis? Well, the most common form of arthritis is what's considered just normal wear and tear. And the medical term we use for that is osteoarthritis, which just means bone arthritis. There are other kinds of arthritis, like inflammatory types of arthritis or rheumatoid arthritis, or arthritis that takes place after major trauma or injury. But the majority of what we see is the end of the bones or the cartilage wearing away, and that's called osteoarthritis. As that happens, the body can create bone spurs around the joint, which are just a reaction to the loss of cartilage. And it creates pain, and it's pain that people typically have every day, mostly with activities that require weight bearing, such as walking or stair climbing. And things that people previously enjoyed start to become less enjoyable, and they become limited by their pain. Most of the time, this happens in individuals typically over the age of 60, but we see patients even much younger in their 40s that are affected by this. And a lot of times women are much more commonly affected than men, particularly in regards to knee arthritis. So the symptoms most of the time is pain. And pain comes in the form of what people describe as a deep ache that's sometimes always present and typically gets worse with activity. Sometimes that even bothers people at night when they're sleeping. You can get swelling within the affected joint and stiffness as a result. Some people, particularly with hip arthritis, describe things like putting on their shoes becoming extremely difficult because of how stiff the joint has become. And eventually it interferes with your ability to do basic things. So as it pertains to the knee, there are different treatment options, and they fall in two categories, which one is surgery and one is not surgery. So the things that you can do before you reach that point of considering a knee replacement. Number one, doing things differently. So if it hurts, we say don't do it. So that's modifying your lifestyle and the things that you do, which a lot of times is not what people want to do because it leads to less activity, and it can create issues with depression and things if you're not able to do stuff that you once previously enjoyed. Weight control is a big piece. Keeping your weight in a healthy range obviously decreases the impact that you're going to put through the joints that you're walking on. So we really emphasize keeping a nice healthy weight in order to decrease the strain that you're putting through your hips and your knees. Exercise and therapy, it seems counterintuitive, but doing some activity is better than doing none when it pertains to an arthritic joint, because they like to be moved, and so it's finding that right amount of activity to keep the joint feeling good. Medications, typically we recommend, if you're able to take them, anti-inflammatory medications. Those are things such as Advil, Motrin, Aleve, and those help to decrease inflammation that's created within an arthritic joint. Other medications for pain that people try are things like Tylenol, and there are all kinds of topical creams and things which are available that some people say is beneficial in terms of relieving some of their pain. Beyond that, there are different kinds of injections. The main injection that we use is a steroid injection, and a steroid is just a very powerful anti-inflammatory medicine that goes directly into the joint. There are other injections, we put them under the category of joint fluid therapy or hyaluronic acid. Other people refer to them as lubricating shots, and those shots are only for knee replacements. They're not approved for hips, only for knees. They're not approved for hips. And the data is fairly mixed on those, but some people find a benefit from them, and it's something to discuss with your doctor if you're a good candidate for them. And then knees in particular, there are certain patterns of arthritis that do very well with bracing, and those braces can help relieve some of the strain on the worn out parts of the joint. And again, that would be something to discuss with your doctor if your particular pattern of arthritis would benefit from it. So again, we'll just run through these. So obviously, weight reduction and exercise is extremely important, helps decrease the load on the joints. As we discussed, the different medications, just to review, Tylenol, anti-inflammatories, and topicals. We typically try to stay away from narcotic pain medication. There's good research now that shows that people that are on narcotic pain medication have worse outcomes if they ever get to the point of a hip or knee replacement. So we tried to avoid those if possible, or limit their use. And then the injections, which we talked about. Typically, the lubricating shot is given in a series of 3 injections versus a steroid medicine, which is 1 injection that can be given every 3 to 4 months. And then knees in particular, we talked about the supplementation or the hyaluronic acid shots, and then the brace, which looks something like this. There's some newer braces which are less cumbersome that fit very well under like a pair of pants that we've been using more and more, that some people have good results from. So when those things fail and they no longer provide symptom relief, that's the time when we consider knee replacement. And I always ask people when they're considering it 3 basic questions, which is, do you have pain every single day? Is it limiting your ability to do activities that you enjoy? And is it negatively affecting your quality of life? And are the options we've tried no longer helping? So when those things, the answer to those things are yes, that's when we start to consider knee replacement. So with knee replacement, what we're basically doing is removing all the bad parts. So that essentially involves shaving off the ends of the bone and removing all the damaged cartilage. And in their place, we put metal and plastic. As you can see in this picture here, this shows a bad damaged joint, and then essentially cutting off the ends of the bone, where we're really only taking away the portion of the bone that is the same thickness as the metal. So I think there's a misnomer that we sort of chop the knee off and put a new one in. If you think about it, it's really more like recapping a tooth in terms of what it's like. And so on the end of the thigh bone then goes a metal cap that looks just like this. And that usually gets cemented on with a very special material. We just call it bone cement, and it holds it for very strongly for a long time. The same thing on the top of the shin bone. We just shave off that bad cartilage. It's the same thickness as the metal and plastic that take its place. And then this new metal plate gets cemented onto the bone, and then a plastic liner snaps in between. So this is basically the steps. You have a very bad knee. We use special jigs and a lot of measurements and calculations to make sure these cuts are placed very accurately and precisely. And then those implants get cemented onto the end of the bones, and that makes up the joint replacement. Typically after surgery, you go up to the hospital floor, where most people get up and get walking the very same day. Most people stay 1 night in the hospital, and they go home the very next day. Typically, it's less than 24 hours that you're with us. Some people are candidates to go home the day of surgery, but a lot of that depends on your overall health and your help at home. And there are some questions about materials that I'm seeing on the knee replacements, and I have a slide that we'll go over here in just a minute that will go over what materials are used. And then there was another question about, can you stop the wear and tear? Unfortunately, with arthritis, it doesn't go away, and you can't really change its course. We're not quite there yet in terms of science and technology. So when a knee or hip is wearing out, it's going to wear out. And there's not much we can do to slow it down, unfortunately. It's managing the symptoms of the arthritic process. Hopefully in the future, there will be some sort of technology so that we can reverse the process or slow it down. But as far as we are right now, we don't have anything to stop it from happening or slow it down. So getting back to surgery here, again, most people go home the very next day, and then we see you back in our office. We follow you very closely, typically between 2 and 3 weeks after surgery, and then between 6 and 8 weeks after surgery, at which point most patients are back to most of the activities they enjoy. And then we follow you very closely for the lifetime of that joint replacement. We usually see everyone 1 year from the date of surgery, and then we see you every 5 years thereafter to follow it, like I said, for the lifetime of the hip or knee replacement. So that brings up the question of how long do these parts last? And the reality is they won't last forever, but we certainly hope that they last most people's lifetime. The issue is you have metal rubbing against plastic, and to the best of the technology right now, these parts last a very long time when rubbing together, but there is always the possibility of a very small amount of debris being formed from these parts rubbing together. And that debris creates irritation within a joint replacement. And that irritation can, over time, cause the parts to come loose. One of the biggest advancements that we've seen in the last 10 to 15 years is these plastics have improved significantly, where we no longer see the kind of wear that we used to see with knees that were put in 20 or more years ago. As a result, we're seeing less complications related to plastic wear, and therefore less of an issue of loosening over time. In a patient who is around the age of 65, we predict, which we can't do 100%, but we predict that that joint replacement is going to last 25 years, hopefully more. But with the current data available, that's about the lifetime that we think they'll have. And for most people, we think that will hopefully last well through their lifetime. So as you know, solutions to this metal wear, we've come up with better plastic materials, which is what we're currently using. Both Dr. Ryan and myself use sort of state-of-the-art materials. We primarily use a company called Smith & Nephew. There are a lot of great knees out there, but they have a very good track record with no recent recalls or anything like that, and very good materials that are the most current and up-to-date things in terms of advancements with that plastic wear. And then the metals. Most knee replacements on the thigh bone piece, which is the highly polished piece that's rubbing against plastic, is made of a cobalt chromium alloy. And it's been used for forever in orthopedics. It's a great material. It's very durable. It lasts a very long time. On some patients, particularly those patients that fall in the younger categories that we worry more about the potential for wear, we have a material that we use with Smith & Nephew, which is called oxinium, and that's an oxidized zirconium. It's similar to titanium, but it shares some characteristics of things like ceramics. Ceramics are extremely smooth, and we use them in other parts of orthopedics. And so when this material, when the surface is oxidized, it can be polished much smoother than the traditional things that are used. And so what that's called is oxinium, and it actually is black, just like in this picture here. It's a black, shiny metal. And so it becomes what the company has done the research that it's 4,900 times more resistant to the kinds of abrasion that we see with metal and plastics wearing. So it's much, much smoother is the easiest way to think about it. And what we hope is that that extends the lifetime of a knee replacement in patients. And we use it for, again, patients that are slightly younger and maybe more physically active that are going to put more wear and tear through their knee replacement. And this material, actually oxinium, I think is, the raw material is manufactured actually locally, and it's sent all over the world. But Smith & Nephew is the only company currently that uses this material. And again, this is what we utilize. We did talk a little bit about the plastics, and again, in the last decade or so, they've changed how plastics are made, and they've created this a material which is called highly cross-linked polyethylene. And all that means is plastic that is much stronger and less prone to the normal wear and tear. This is a picture of an old plastic that was taken out. This is a plastic that's probably 20 or 30 years old, and you can see how it wears down. This is what we're no longer experiencing because of the advancements in the materials that we're using. And then again, this is just the knee that we use here. It's called the Legion knee, and this is exactly what most of our patients' x-rays look like. It's designed to create a more natural motion, meaning to hopefully simulate more closely what your knee would feel like. And it comes in a vast array of sizes so that we can find matches for both men and women, because we're not all made the same size and our knees aren't the same size. And then it uses the most up-to-date materials. And if the company calls it the Verilast knee, which is the combination of that material oxinium along with a highly cross-linked plastic. So again, this is as good as the materials get, and a lot of manufacturers make similar types of products. It's just really dependent upon what the surgeon prefers, and this is what Dr. Ryan, I think, is the best knee to put in our hands. And we also use technology to make the placement of the parts better. So what we use they're called customized instrumentation or custom cutting blocks. And essentially what that means is that the jigs in which we use to place the parts and cut the ends of the bones, we use technology to create 3D printed blocks that snap on to the end of your bones like a puzzle piece. They'll snap on around the bone spurs and all the wear and tear on the knee to allow us to make the cuts very accurately and precisely. This picture just shows all the different measurements that we take. And traditionally, when we do a knee replacement, which we still do very frequently, we're measuring these things inside of the person at the time of surgery. And most of the time that leads to very good outcomes. But in order to make it more accurate and more precise, we use this Visionaire technology. There are some patients that are not candidates for it because it does require an MRI scan. But in the majority of patients that are candidates or that we have time, because this takes at least 6 weeks to manufacture, we try to get this done. And it uses a special MRI scan and a special X-ray. And from that, we use computer software, and we have an engineer at Smith & Nephew that helps create these for us in order to make these customized blocks that fit on your bone. So this is some of the computer software that they use to analyze your bone and make the blocks fit very precisely. For us, it reduces the operative time. We save anywhere from probably 5 to 10 minutes of time during the surgery. And the benefit of shorter surgery is obviously you're under anesthesia for a shorter period of time, and it potentially can reduce your risks of things such as blood clots if we can move much more quickly through the procedure. So when we look back at knee replacement, obviously knee arthritis, it's very painful. And there are options to maximize before you reach knee replacement, which we talked about: injections, bracing, weight loss therapy. And then when those things no longer are helping and your quality of life is affected, that's when we consider knee replacement. And again, the materials that Dr. Ryan and I use, we think are what's some of the best stuff on the market. But again, every manufacturer is using or has available these very modern implants that hopefully will last a very long time. So hip replacement, very similar in terms of materials, but obviously a very different joint that we're replacing. So with a hip, it's comprised of parts that go down into the thigh bone or the femur, and then parts that go attached into the pelvis. And essentially, it's very similar to knee replacement, where we're removing the bad parts and putting the new ones in. Most of the time in a hip replacement, which is different from a knee replacement, the parts are designed for your bone to grow onto them, as opposed to being cemented in. There are some patients where the bone quality is not good, where using a implant where the bone grows onto it places them at risk for things like fracture, in which case we use cement to hold the thigh bone piece in. Outcomes for both are very similar and very good. It's more so dependent on bone quality to determine which type of fixation is best for each patient. So with hip replacement, what we do is we actually remove the ball from the ball and socket. And then inside of the thigh bone, we use what's look like wood rasps to shape the inside of the thigh bone to fit the stem that goes down inside perfectly. Inside of the socket, we scrape out all the bad cartilage, remove all the bone spurs, and a new metal cup then goes inside. So this is a picture showing that stem going down inside the metal cup with a plastic liner snapped in between. And these parts are primarily made of a metal called titanium, because titanium works very well with our bone. And in a hip replacement, the only piece that's rubbing against plastic is the ball. And we'll talk about that here in just a second. That ball snaps on top to the thigh bone piece or the stem. And then those come together to recreate the ball in the socket. So again, to walk through it, we remove the bad parts. We cut off the ball of the ball and socket. We scrape out the cartilage within the socket or the acetabulum. We put the pieces inside the bone where that plastic liner snaps into the cup. And then the ball, which is what is rubbing against the plastic, is again made of that zirconium material, or that oxidized zirconium, called oxinium. And it has very good longevity and wear, and it's a good material that we use not infrequently. Actually, every hip replacement has an oxinium ball. After surgery, it's very, very similar in terms of recovery. You typically get up and walking the same day. Most patients stay one night in the hospital, go home the next day. And then there's a subset of patients that are candidates for same-day surgery where they can discharge home that very day. And again, with hip replacement, how long do they last? We hope that they last, again, 25 or more years. The issues are similar. You have metal rubbing against plastic, and that can create issues down the road where over time they wear out. And again, historically, looking at hips that were replaced 20 or more years ago, what we would see is that plastic causing a problem where then the parts would come loose. But we're not seeing that as much anymore. In fact, it's extremely infrequent with modern joint replacement to see the issues with the plastic wearing out because the technology has improved. And so we want the parts to grow in well to the bone, and we want it to have very smooth surfaces to create any amount of wear. And for the most part, we're very close. And this is, again, the technology that we use. It's called the combination of oxinium with a highly cross-linked polyethylene, or a highly cross-linked plastic, which means it's very strong and very smooth. That's the Verilast technology that we use, which is by the Smith & Nephew. Again, many manufacturers make parts similar to this that have very good longevity. So again, this is what they look like. This is the ball that we use. Again, it's that black shiny metal. The traditional ball made of cobalt and chrome, we've actually gone away from using those for the most part, just because there's, again, they're not as smooth and there's more issues with compatibility between the metals. And then a lot of manufacturers offer also a ceramic head. We choose to use oxinium because it's smooth like a ceramic, but it's hard like a metal, so it has the best of both properties. So again, hip arthritis, it's a painful process that typically creates pain within patients' groin that radiates down into their thigh and makes walking and activities of weight bearing very painful. The non-surgical options, which we discussed, weight loss, activity modification, injections, when those things no longer alleviate pain, that's when we discuss the possibility of hip replacement. And again, the technology has improved substantially over the last several years where, you know, the complications that we were once seeing are much reduced. Have a joint replacement? Most of the time it's because people don't want to live in pain anymore. And that's what it does, is primarily it's a pain relieving surgery. It's a quality of life surgery. It allows people to have more mobility, to live a more active life, and be able to do things that they couldn't do because of their the pain within their joints. So that's the overview of joint replacement. I'll say for both myself and Dr. Ryan, this is all that we do. He and I both do exclusively hip and knee replacements, and we fix problems related to hip and knee replacements. So we do what's called revision surgery on those parts. We see a lot of patients that had joints put in 20 and 30 years ago that are having issues that need to be somehow fixed. So for those that are interested or think that you may be a candidate, if you haven't started the process, we always encourage you to see your primary care doctor and find out if you do actually have arthritis, which is very easy to find out with an x-ray. And if you are suffering from debilitating arthritis, it's pretty streamlined to come in and see us. Both he and I are located here. Our main offices are here in Albany, and we do all of our surgeries through the Center of Excellence here at the Albany Hospital. And I guess I'll open it up to questions, whether you want to type those in, or you're more than welcome to unmute yourself and ask a question in person if you'd prefer. I guess to Cheryl, I'll ask, hopefully I answered the question with regards to the materials. You also asked if you can get a second knee replacement in the same knee. And can you? Yes. The reasons to have repeat surgeries would be for like things wearing out, or the more rare complication of like infections. Those are reasons that we might go back into a knee replacement and have to redo it for some reason. It's extremely rare to have a revision. Again, we would see it more in, say, a patient who had a knee replacement at the age of 45, where the likelihood of that knee lasting their lifetime is lower, because in 30 years, when they're in their 70s, there's a higher chance that they may need a revision for some reason, in which case you can have a repeat surgery done where we go in and change the parts out and make them, I guess, new again. So hopefully that answered the most of the question. Any other questions?
I have a question.
Go ahead.
And I'm Mary Ellen Lind. Can you hear me?
Yep, go ahead.
Okay. I have an appointment with Dr. Ryan coming up, but I'm wondering, I'm having more problem with my, that would be my right knee, but I have terrible problem now with my left ankle.
Mm-hmm.
So which would he want to fix first?
Well, that really depends on what the problem is with your ankle, and if you've had it looked at. If you already have an appointment with him, when he comes in, he'll be able to do a full physical exam and determine if the ankle would limit your recovery from a knee replacement and if it needed to be addressed first. If for some reason he thought there was an issue with your ankle, he can always make a referral to another provider to get it looked at before you consider knee replacement. So if you have an appointment, I would just recommend keeping it just so you can get a full evaluation of that side and see if, number one, if the two are related to each other or if there's something additional that needs to be done. So I keep the appointment and let him just evaluate it. That's what I would do if I saw you, is just make sure. And then if you needed to be referred for the ankle, we could address that at the same time. Are there any other questions? Or hopefully that, if there's a follow-up, hopefully that answers that.
Hello?
Yes.
We couldn't get the video to work, so we missed out on all the pictures. Is there any way that we might be able to see, like, get an email with the pictures, or we're kind of out of luck?
I can defer to Aaron, who coordinated this, to see if we can send out that PowerPoint presentation to review.
Okay.
Yes, this recording will be sent to your email that you registered with, and you will be able to view it later.
Okay, good, because we couldn't get it to work, and thankfully support person sent me a telephone number so I could call and at least hear it.
I see. Yeah. Yeah, you'll be able to watch it again, I guess, listen to it all over again.
Okay, well, I appreciate it.
Yeah, sorry about that.
Oh, that's okay.
Any other questions? There's a couple here. This says, I'll just go ahead and read them out. I have an arthritic knee that is not symptomatic, but it was diagnosed on x-ray, no pain or issues. However, I have intense pain with standing in the calf and thigh. It feels like the tendon is tearing. Standing is a problem, not walking. Will a joint replacement do anything? Is there anything else that can be done? You know, in the case where you don't have a lot of pain, but you do have arthritis, and just because you have arthritis doesn't mean you need a joint replacement. But in those scenarios, that's when I really would recommend utilizing conservative treatments first, particularly in that case, knee injections, to see if your pain is improved with the knee injection. If it is, then that may be enough to get you by. And then the other piece of an injection is if you get a knee injection and it makes all of your pain go away, then you know that the knee arthritis is causing those other areas of pain. Some people have atypical patterns of pain, meaning they have arthritis in their knee, or more commonly arthritis in the hip, but it doesn't cause pain within the hip. It actually causes pain in the thigh or in the knee. And that's just a less common referral pattern of the pain. So sometimes an injection can help to both alleviate your pain and let us know if the hip is causing it. So in that particular case, I would start with conservative treatments to try to figure out exactly what's causing it. Because if it is just a muscular issue, you may benefit from therapy or other things. So that's kind of where I would start if you're not sure if the arthritis, even though it's on an x-ray, it doesn't mean that it causes you pain. And then there was another question about approaches to hip replacement, which I didn't get into in this presentation specifically, but when we talk about hip replacement, there are two common ways to get into the joint. One is called an anterior approach, which means an incision through the front, and then a posterior approach, which is an incision through the back, which kind of goes over the buttocks. And I do exclusively anterior approach hip replacements. I'd say 95% of patients. Some are not good candidates for it. And then Dr. Ryan does pretty much exclusively posterior hip replacements. And in that scenario, there are pluses and minuses to both. And it really depends on, number one, your pattern of arthritis and your body, so to speak. Some people aren't good candidates for one or the other because of body habitus or people that have extremely a lot of laxity in their joints. They may be better suited to have an anterior hip replacement because this risk of dislocation or the ball popping out of socket is slightly less. If you look at the studies on both of them, and there's lots of studies that have come out over the last 5 to 10 years, the outcomes are very, very similar, meaning regardless of what you have, the likelihood of a good outcome is very, very high. And there are certain nuances to each. Some studies show that the early recovery from an anterior hip is faster, but that data is not 100%, meaning some people heal much better from a posterior approach. So it's really patient specific, and I would say surgeon specific as well. In my hands, I think I do better with an anterior hip replacement, and Dr. Ryan's, he does better with the posterior. So the thing is having a surgeon that has a lot of experience, that's done hundreds and hundreds of them in whichever way that they do it, and have a good track record of good outcomes. And I think that both Dr. Ryan and myself have that and can provide that. So it's sort of a patient preference thereafter, I think. Any other questions? Let's see. There was a question about the recommended prep prior to hip surgery. And I'm not sure if that is related to the preoperative process, which for us, it's fairly extensive. I can walk you through what we do. So at the time that you usually have your consultation with us, if you decide to have a joint replacement and choose a surgery date, we have you then see your primary care doctor. He or she clears you for surgery. We also get a series of labs, which include an EKG, where we check your blood counts, your kidney, your liver. We do a lot on the infection prevention side, where we also check your nose for bacteria, your urine for bacteria. We make sure that if there's anything that needs to be treated on you beforehand to decrease risk for infection, that we do that. And there's also a class at the hospital that's required, where you meet nurses, therapists, discharge planners. They teach you everything that you need to know about having a hip or knee replacement. And that all takes place within usually the 4 weeks leading up to your surgery. And then there's stuff that you do at home, special soaps that you wash your skin with, that you do before surgery. And that's kind of the process leading up to it. And we always see you about a week before your procedure to review everything for a preoperative visit. So that's the process. I think that's what you're asking. If not, go ahead and clarify, and I can elaborate on that. And then another question, how long of recovery time to be on your own? Usually after surgery, we recommend that somebody is able to stay with you for the first, 5 days. You don't need 24-hour care by any means, but we prefer someone be available at night just in case if you were to fall down or something, you want someone there to help you. But usually by a week or so, most people are getting back to fairly independent. Before you leave the hospital, we expect that you get in and out of bed on your own. You can walk up and down steps which your therapist will practice with. You can do all of your own care in regards to bathrooming and showering, and we walk you through all that. But the goal is to make sure that you are able to function and do all the things on your own, knowing that you do need a little bit of help. There was a question from Cheryl that says ASU question mark. I'm not sure what that means, if you want to elaborate on that. And then return to downhill skiing after knee replacement. In regards to getting back to those activities with knees, what I usually tell people is a knee replacement is made for most things that are not high impact. So if you were a good skier beforehand, say you skied difficult black diamonds, my recommendation is usually take your intensity of skiing down a bit. I don't recommend moguls or really difficult terrain, but if you're a very good skier, skiing blues or easy blacks is very reasonable to do. You're at risk just like everyone else. If you fell, you could have a ligamentous injury to your knee, which would not be good in a knee replacement, but it wouldn't be good in a normal knee anyway. So you're at risk for the same kind of injuries that most people would experience. But as long as skiing is something that you did before, I wouldn't take it up as a new hobby, but it's relatively safe to do. And if it's something you really enjoyed, that's a reason to have a knee replacement, to be able to return to that kind of activity again. This is Cheryl. I don't know about the, it's avocado soy unsophifiables. I don't know much. I haven't seen much in the joint replacement literature about that as a supplement. Most of the supplements that are out there for, joint health, the data on them is fairly mixed in terms of the data that we see. And usually my recommendation is, if it helps, take it. And so, trying any of those things, another common one is like MSM or now it's leaving my mind. I think chondroitin for joints. So those things, again, the data is mixed on them, but I have a lot of patients that say they help tremendously. And so if it doesn't cause side effects and you feel that it helps with your joints, I think it's absolutely worth trying. And then I think there's another question about exercise rec. I think maybe that means recommendations for exercise. If it's in terms of arthritis, just keeping moving. So low impact exercise, whether that's walking, biking, easy weightlifting, swimming, those things are all very good for arthritic joints. And those things are also very good after joint replacement. So it's about keeping active and keeping your muscles fit. And all those things are very helpful. And then, can you use a different metal than titanium in hip replacement? Yes, you can. Titanium is the most, I would say, biocompatible with bone, meaning it has the best track record for growing in and longevity. And it's fairly inert, meaning it doesn't tend to react inside the body. Most patients that have issues with metal, their allergy is actually to nickel. And nickel is in many of the alloys, such as a cobalt and chromium, which is why we have gone away from using it in a lot of scenarios. So in a hip replacement, titanium within the socket or the cup side tends to have the best ingrowth, meaning it stays very well. And the same thing in the thigh bone piece, which is also made of titanium. It's the most inert in the body, and so that's why we prefer it. The key is using a highly polished ball, like the oxinium ball that I talked about. So in terms of hip replacements, there are not a lot of alternatives to titanium, except as it is in regards to the ball or the bearing surface. And then another question, after hip replacement, can you still do yoga? Yes, you can, but you have to be careful. Hip replacements carries the risk of the hip popping out of socket or dislocating. And that's because a hip replacement changes the dynamics of the hip slightly. And so there are certain positions that we want you to avoid. Those are deep bending with twisting, because those put you at risk for the hip popping out of socket. Everyone with a hip replacement is at risk within their lifetime. It's about a 1 to 2% lifetime risk of a dislocation or a hip popping out. And so if you choose to do yoga, you want to let your instructor know, or you keep in mind the precautions so that you're not getting in positions that put you at risk for it popping out. So it's a matter of sort of changing some of those poses so that you can do those things. And then another question here. With both knees, I cannot kneel on my knees without significant pain. Also, bone protrusion at the top of the shin bone. Are the bone protrusions causing my pain? Sometimes they can be, particularly if it's only with kneeling, meaning it's just the pressure of that bone. And that's a tough thing to fix. Most of the time, what we recommend is to modify the activities, wear knee pads, or try to avoid that positioning. If it's a question of is that possibly related to arthritis, most of the time arthritis isn't a pain with kneeling, it's more so with weight bearing, walking, stair climbing, not just putting pressure on the knees when kneeling by itself. All right, any other questions, whether through the mic or in the chat? I'm scrolling back through, I think I got most of them. If not, we can kind of wrap things up and summarize some of this in the email that will come out to you. It looks like Erin posted a link to a survey that we asked that if you are able to do it and just give us feedback so we can make these presentations better or more applicable for you in the future, we can. And then again, everyone that joined or had an email confirmation for this should get an email with a recording of the presentation. So that you can reference it back if you needed to. And again, if you want to seek our services or feel like you're at a point of joint replacement, our phone number is up here, and we're happy to see you for consultation and to decide if joint replacement is right for you. Erin, did you have anything else?
No, that's all the time that we have for today. So thank you again for joining us. Your feedback is valued. If you could please take a moment to complete the brief survey, which is now available in the Q&A box. And then please watch for the follow-up email that will include a link to the recording as well as that survey. Thanks again and have a great day.